Good afternoon, and thank you for joining Part 2 of MTBC's webinar series regarding Medicare Accountable Care Organizations. For those who missed Part 1 of this series on Accountable Care Organizations, which are otherwise known by the acronym ACO, please feel free to visit our website www.mtbc.com to view a recording of Part 1. Today's focus will be upon the practical considerations in establishing a Medicare Shared Savings Program, ACO. My name is Steve Snyder. I serve as the president of MTBC, a leading healthcare IT, revenue cycle management, and practice management company serving providers throughout the U.S. I'm an attorney by background. I'm also joined by my colleague Hamza Rahman. Hamza serves as our Chief Business Intelligence Officer. He's also a certified information systems analyst and a chartered accountant. Before we delve more deeply into the topic of an ACO, let's just consider some of the background. First of all, what is an ACO? Quite simply, an ACO is a group of providers or service suppliers who agree to work together in order to coordinate care for Medicare fee-for-service patients with the goal of improving the quality of that care and also reducing the costs associated with delivering that care. This ACO model is an outgrowth and is built upon the Patient Protection and Affordable Care Act, otherwise known as PPACA, and also otherwise known as Obamacare. The ACO was created in the PPACA, but the final rules really took shape when CMS issued its rules on October 20th, 2011. This concept of an ACO, or an accountable care group, is not necessarily a new concept, nor are the drivers upon which it's based. In particular, the drivers of reducing cost and improving quality of care. There are predecessors in the commercial reimbursement world, and there are also some touchstones or points of reference, some predecessors within the Medicare world as well. Things like PQRI or PQRS, things like the meaningful use incentives created to reward providers who utilize in a meaningful way certified electronic health records technology, and these electronic health records software programs, or EHRs, lay the foundation for this interconnected network of providers who then become accountable in the accountable care organization model. The rules created three types of ACOs. The first type is the type we'll be looking at today. That's the Medicare Shared Savings Program model. That's comprised of a one-sided program or a one-sided plan and a two-sided plan. It also created the Advanced Payment Initiative model and also the Pioneer model. We will not be looking at the other two models today. Instead, our focus will be upon the Medicare Shared Savings Program, or MSSP is the acronym that's commonly used to refer to this program. Let's take a minute and look at some of the characteristics of the existing approved ACOs that are doing business today in the U.S. and are approved by Medicare. You'll note that with regard to the geographic distribution of the ACOs that have been approved by Medicare and are doing business today, there's a large concentration of those ACOs in the Midwest and also on the East Coast. Please note that this particular map contains Pioneer ACO details, that's the light or the aqua blue, together with the Shared Savings Program ACOs, which are depicted in red and purple. And as I mentioned before, today's focus is on the latter, the shared savings ACOs. It's not on the pioneer ACOs. Let's look for a minute, as a point of reference, at the latest group of approved ACOs, the 88 ACOs that were approved in July of 2012. With regard to that particular group of ACOs, and this seems to be relatively representative of the overall group of Medicare Shared Savings Program ACOs, 42% of those ACOs consist of 200 or fewer providers, and a full 70% have 400 or fewer providers. A slim minority, 16%, are groups comprised of 1,000 or more providers. Let's turn our focus for a minute to the subject of hospital affiliation. While the ACO model lends itself well to an association or an affiliation with a hospital, and having a hospital be a member of that ACO, it's not necessary. And in fact, a slight majority, 56%, of the ACOs approved in July of 2012 did not contain a hospital, while 44%, as you'll note, are in fact affiliated with a hospital partner who is a member and identified as part of that ACO. That's a little bit about the overall characteristics of the Medicare Shared Savings ACOs that are doing business today and are approved by ACO. Let's turn our focus now to the key organizational requirements for the ACOs. First of all, ACOs must have a minimum of 5,000 Medicare beneficiaries. That is 5,000 Medicare beneficiaries who are associated with the providers who are a group and are members of that particular ACO. Likewise, while Medicare has not set a specific minimum number, Medicare will require that the number of primary care providers that are associated with that particular ACO and identified in the application, that number of primary care providers is sufficiently large to manage the number of Medicare beneficiaries who are also associated with that ACO. In addition, Medicare requires that the providers who are forming the ACO enter into a 3-year agreement with Medicare that defines the respective responsibilities and also the remuneration with regard to the ACO. Fourth, in order to be approved as an ACO, the ACO must identify all of the providers or suppliers who are associated with that ACO and must certify through a representative that the providers associated with that ACO or who are members of that ACO are committed to being accountable for the quality, the cost, and the overall care provided to the Medicare beneficiaries. In particular, and we won't get into all of the micro-level details in terms of some of the other requirements, but other things that will be required will be things such as there has to be a board-certified physician who's designated as the medical director. In addition, the governing body of the ACO, at least 75% of the control of that governing body of the ACO must be the ACO participants themselves. They must be able to control the governing body of that ACO. These, in a nutshell, are the threshold requirements associated with the ACO. Let's just view for a minute some of the key elements of the application. So, if we have a group of providers who have made a decision that they'd like to form an ACO and they'd like to be reimbursed under the ACO Shared Savings Program model, the next step will be, after performing the due diligence and and analyzing whether or not they think that they're capable of doing so. The next step will be preparing an application. That application consists of a number of key elements. First of all, the ACO participants have to identify the organization, the key contact individuals associated with that organization, the entity type. For instance, is this an LLC? Is it a corporation, a C corporation, or an S corporation? Is it a PLLC? There's no particular requirement with regard to the type of entity. Instead, Medicare has allowed providers to choose their own entity type under state law. In addition, with regard to the entity, it's important to note something. Independent providers can form an ACO for Medicare reimbursement purposes only and can otherwise operate their own practices for purposes of self-pay patients or for commercial reimbursement, or they can join together as a group practice or a hospital-affiliated practice under one tax ID for all submissions and submit and act as a group for all purposes. Both models are permissible in the ACO world. Secondly, we've already touched a little bit on the governance and the leadership. As part of the application, one will have to submit an organizational chart, details of the respective committees, the job descriptions of some of the key team members, details with regard to the officers and the like, the details of the governing body, a description of the control provisions and the like, and also confirmation that a compliance program or plan has been created, that there's a clinical management oversight function that's been well thought through and designed and documented. And also we'll have to have these details available for Medicare if Medicare ever decides to perform an audit or to request copies of these particular documents. Third, with regard to the financial matters, Medicare requires that the applicant provide a narrative regarding the approach that it will take to achieve the goals of the ACO, i.e. the goals of increasing the quality of care while reducing costs. Medicare wants to also understand the methodology of the shared savings, and we'll get to that in a minute, but Medicare would like to understand how any of the shared savings distributions will be handled and allocated among the respective providers. In addition, in financial terms, if in fact a particular track is selected, that's the track that also provides for a shared loss, Medicare would like to know whether or not there's reinsurance or escrow or a bond in place to cover that repayment. Next, provider information will be required, copies of the ACO participation agreements with the providers, and a list of the participants. Next, data sharing. Medicare would like to know whether or not the ACO will request Medicare's data with regard to the particular patients associated with the ACO. This information parenthetically is used to create a baseline for measuring the savings or the increase in costs associated with the care being provided. Also, Medicare would like the ACO applicant to make certain representations regarding how it intends to use that data. Finally, the application most notably will require the applicants to provide certain clinical process and patient-centeredness details, an overall narrative and a description of its strategies, its methodologies, and its approach to ensuring that the quality of care provided to the patients will be an improved quality of care compared to a traditional fee-for-service model. Medicare also wants to understand the metrics that will be used to measure this particular performance. In terms of the overall application process flow and the approximate timeline, the first step in the timeline is the filing of a notice of intent. approximately 30 to 70 days after that, the application can be filed. The application, denial, or approval will come about 130 days after the notice of intent is first permitted to be filed, i.e. the initial permitted acceptance date for the notice of intent, because these applications open up in Windows. 140 days later, there's a review and a reconsideration with regard to any denials. And then finally, the entire time span between the opening of the notice of intent period and the final go live is approximately 150 days, roughly. Please note that with regard to the next window, the next window will lead up to a start date of January 1, 2014. So CMS has confirmed that it expects the applications to be available sometime during the early part of the second quarter of 2013. However, at present, there are no pending applications, nor is the window open with regard to ACO applications. So it's an important time right now if you're considering an ACO. It's a very important and critical time to begin to pull all the pieces together, to create the documents, to obtain buy-in from providers, and to create the entity structure, and to get ready for that window to open for the NOI, because that will not happen until sometime again in the second quarter, early part of the second quarter of 2013. I'll turn the floor over to my colleague Hamza in a minute, but before that, let me just briefly address the compensation model. The compensation model is a hybrid, with the floor or the base compensation being the fee-for-service compensation or reimbursement that is offered to all participating Medicare providers. So those participating as an ACO will continue to receive fee-for-service payments relative to the services performed. However, unlike the traditional fee-for-service model, ACO participants will also have the opportunity to share in the savings. I'll turn the floor over now to Hamza, who will provide a more detailed walkthrough of those shared savings, and also the implications associated with the two-sided model relative to the lack of savings or the increase in costs if in fact such an eventuality were to occur. Hamza, if you could take over from here, please.
Thank you, Steve. Good afternoon, everybody. I'd just like to take a moment to recap what we've covered so far. So Steve's talked about the characteristics of existing MSSP ACOs. He's also introduced us to the application process and the timelines that are involved with that. The question that I'm going to be tackling right now is perhaps one of the most important questions on the minds of anyone who's considering the ACO option. And that is that if we do go for the ACO program, what kind of changes are there going to be in our practice's cash flows? And the answer to that is that there will be no immediate changes. Providers will continue to receive payments under the Medicare fee-for-service arrangements as they do currently. That's because in the final ruling, CMS indicated that Medicare will make no changes to its fee-for-service arrangements. So ACO participants will continue to receive payments as they do at present. After the first reporting period, which for existing ACOs is 31st December 2013, and for future ACOs it will be a year from the agreement start date, Medicare will determine the total savings or losses that the ACO has realized and will either pay the ACO for its share of savings realized or require the ACO to pay Medicare for its share of losses that may have been realized. So the next question that comes is, how is the share of savings or losses determined, and what kind of numbers and percentages are we looking at? Well, the calculations are a little tricky, so what I'm going to do is to run you through a practical example and explain each of the elements as we go along to make it as simple as we possibly can. The first thing that we have to understand is that the final rule provides for two tracks of the MSSP. The first track, called the one-sided model, entitles an ACO to take part in any savings that it has realized at the end of the reporting period. The two-sided model not only allows an ACO to take part in any savings that have been realized at the end of the reporting period, but also requires it to bear the burden of any losses that it may have incurred. In other words, the one-sided model is a profit-only model, whereas the two-sided model is a profit and loss sharing model. Now, there are a number of differences between these two models, and I'll highlight those as we run through the example. Now, for the sake of this example, we're going to use two ACOs. They're similar in every respect except that one has opted for the one-sided model and the other has opted for the two-sided model. So, first of all, the number of beneficiaries. Each of the ACOs has a beneficiary base of 16,000 patients, which was determined at the time of filling out the application. Also, the benchmark cost for each of these ACOs is $10 million, also determined at the time that the application was filed. Now let's assume that at the end of the first reporting period, 31st December 2013, it's determined that each of our ACOs has attained a savings of $300,000 each. That translates to 3% of the benchmark. Now the next question is, are these savings adequate to entitle our ACOs to a share in the total savings of $300,000 which they have realized? Now, to answer that question, the final rule provides for a minimum savings rate. If an ACO attains savings of up to at least the minimum savings rate, then it qualifies for a share of the total savings. Now, the two-sided model is simpler, so we'll tackle that first in this regard. For the two-sided model, the rule states that if an ACO demonstrates savings of at least 2%, then it will be entitled to share in the total savings. In our case, we've accomplished savings of 3%. In other words, we've crossed the threshold and we'll be entitled to participate in the savings. Now, the one-sided model is a little more complex because the minimum saving rate is not a flat rate like it was in the two-sided model. Instead, the minimum saving rate for one-sided model ACOs depends upon the number of beneficiaries enrolled with those ACOs. The CMS has done this to rule out any accidental or any random savings or any random losses that may have been incurred. Now, the table that's used to determine the minimum saving rate for the one-sided model is shown here. The first step is to trace in which of these slabs in the first column does our ACO lie in. Now, we have 16,000 beneficiaries. If we move down here, we'll see that in this row here, the 10th row, is where we lie. Now, this slab runs from 15,000 beneficiaries to 19,999 beneficiaries. We have 16,000 beneficiaries, which is at the lower end of this slab. Because we lie on the lower end, the next step is to move to the right-hand side, to the second column, which is the minimum saving rates required if one lies at the lower end of this slab, which is our case, and therefore the minimum savings rate that we must demonstrate is 2.7%. Had we been at the higher end of this slab, so for the sake of demonstration only, suppose that instead of 16,000 patients, we had 18,000 patients. In this case, we would have been at the higher end of this slab, and the relevant column for us would have been the third column, which says that the minimum savings rate is 2.5%. In other words, the higher the number of patients that you have, the lower the minimum savings rate that you will be required to demonstrate. Returning to our example, the minimum savings rate that's relevant to us is 2.7%. So, the minimum saving rate being 2.7% and the actual being 3%, this means that our one-sided ACO model also qualifies to receive a share of the ACO's savings. So, that's the very first difference between the one-sided model and the two-sided model, i.e., the two-sided model has a flat minimum savings rate of 2%, whereas the one-sided model has a sliding minimum rate dependent upon the number of beneficiaries. The greater the number of beneficiaries, the lower the rate that you're required to demonstrate. The second difference is the maximum share to which you're going to be entitled. So we've determined that we are eligible for a share of the savings. The next question comes, to what extent are we eligible? Now, to answer that, the first thing that we need to consider is the maximum percentage to which an ACO is entitled. If you're participating in the one-sided model, you're entitled to a maximum of 50% of the savings that you may have realized. Whereas, if you're participating in the two-sided model, you'll be entitled to a maximum of 60% of the savings that you've realized. In other words, participants of the two-sided model are entitled to an extra 10% for taking on the greater risk of the losses that you may be required to share in. So, having determined the maximum possible percentage to which you're entitled, the next step is to determine the actual percentage. Now, in order to determine that, CMS indicates that each ACO will be ranked across 33 quality metrics. The CMS has identified these 33 quality metrics, and the ACO will be graded at the end of the reporting period in each of these 33 metrics. And the grade across each of these 33 metrics will then be averaged to arrive at your final performance score. Let's assume that in our case, each of our ACOs achieved 50% on average across these 33 metrics. The next step, in order to determine the actual share of the savings of $300,000 which we've accomplished, we have to multiply the maximum saving percentage by the actual performance achieved. So for the one-sided model, we multiply the maximum saving percentage, which is 50%, by the actual performance rating, which is also 50% in our case, which amounts to 25%. In other words, our one-sided ACO participant is entitled to 25% of the savings of $300,000 which it has realized. 25% of $300,000 comes up to $75,000. Turning our attention to the two-sided participant, again, we need to calculate how much of the savings it's actually entitled to. In order to do that, you multiply 60%, being the maximum share possible, by 50%, which is the ACO's score in the performance metrics. We arrive at 30%. 60% into 50% is equal to 30%. In other words, of the $300,000 that the ACO saved, it will be entitled to 30%, which comes out to be $90,000. So, we've determined that our one-sided ACO participant qualified for savings by attaining a saving rate of 3%. The maximum savings to which it was entitled was 50%. Its actual performance score was also 50%. This entitled it to 25% of $300,000, which is $75,000. In the case of our two-sided model, this participant also qualified for sharing in the savings because it attained 3% of savings. Its maximum possible share percentage was 60%. It also attained 50% in its performance measures, which entitled it to 30% of any savings, which comes out to be $90,000 for the two-sided model. Now, the next penultimate step is to calculate the cap on any savings that the ACO is entitled to. The final rule states that an ACO cannot be entitled to savings in excess of 10% of its benchmark. It also states that for a two-sided participant, the cap on the savings will be 15% of its benchmark. In our case, the benchmark for each of our ACOs was $10 million. Now 10% of that, in the case of the one-sided model, translates to $1 million. And in the case of the two-sided model, 15% of the benchmark translates to $1.5 million. So, in other words, after having calculated the share to which an ACO is entitled, we must compare this to the CMS cap. In our case, $75,000 for the one-sided model is lower than $1 million, which is the cap. In other words, our one-sided model is entitled to the lower of its share and the cap, which is $75,000. Applying the same rule to the two-sided model, the lower of the cap, $1.5 million, and the share, $90,000, gives us $90,000. So, our one-sided participant is entitled to $75,000 and our two-sided participant is entitled to $90,000 in shared savings. Okay, so we've considered the profit side of the picture. The next question is, what happens in the case of a loss? Well, in the case of a loss, the one-sided model ACOs are not required to share in that loss, and so there's nothing further for them to consider. For the two-sided model, of course, since they are required to share the burden of the loss, the calculations will follow the exact same pattern as they did for the case of the profit. However, one difference that arises is when it comes to the cap on the loss share. In the case of the profit share, if you remember, the cap was a simple 15% of the benchmark. In the case of losses, however, CMS has been a little more considerate, and the cap has been placed at 5% of the benchmark for the first year, 7.5% of the benchmark for the second year, and 10% of the benchmark for the third year. In other words, CMS is bearing the greater share of losses than it is taking part in the profits. In other words, even though ACOs in the two-sided model are required to participate in the loss, their losses are going to be limited to just 5% in the first year, 7.5% the benchmark in the second year, and 10% in the third year. Okay, so we've talked about the financial implications of savings and how they're going to be shared with ACOs at the end of each reporting period. We turn our attention now to what an ACO needs to do in order to realize these savings. Well, CMS has identified a number of core competencies, which it believes, if developed by an ACO and worked upon, can realize increases in quality and reduce costs. We've mentioned what we believe are the four major ones here. There are others, but these are by far the most important. First of all, patient-centeredness and engagement. Medicare requires that ACOs place patients at the center stage of the healthcare process. They require that patients be involved in the decision-making process of their treatments, as well as be engaged with relevant and timely information pre- and post-treatment. Next, Medicare requires coordination amongst all healthcare providers. It requires up-to-date information being made available to all participants, whether they be PCPs or specialists or emergency room staff. Next up is the promotion of evidence-based medicine, which involves making use of the most up-to-date and modern techniques and methodologies and research available in deciding on a plan of care for a particular patient's circumstances. And finally, it involves the point of care automation, which requires that as much decision making as possible at the point of care be assisted by technology, by the use of reminders and lists and alerts, for example. We'll go into the details later. So what we're not doing right now is delving into the details and intricacies of implementing each of these 4 requirements and attaining competence in them. Rather, what we're talking about is the framework that underlies success in all 4 of these areas. In order to attain success on all 4 of these and other fronts, ACOs must build infrastructure which provide for 4 themes. These are summarized over here. First of all is access to real-time information. Information must be captured at the point of care, and updated information must be available to all providers, whether they be PCP specialists or even emergency room staff. It must be available instantly and in real time. Next is communication and coordination. All participants must have the ability to disseminate information across all ACO participants and all healthcare participants. So, it's not just about having access to real-time information, it's about disseminating that information to all relevant parties, whether they be within the ACO or whether they be external to the ACO, for example labs and pharmacies, or whether they be between the ACO and the beneficiaries themselves. So, we've talked about having access to real-time information, about disseminating, communicating and coordinating that information to all relevant parties. The next requirement that needs to be fulfilled in order to meet the MSSP requirements is the ability to analyze and report on this information to support decision making. It's not good enough to have real-time information and make that information available to all parties if it's not going to feed into the reporting and decision-making process. And finally, there must be an ability to use this information decision-making to generate more information which feeds into the decision-making loop. In other words, the most up-to-date information decisions made must feed back into the system and be made available to all other participants in the cycle. Now, measurement and control is about taking corrective action. So, for example, if you realize that you're suffering underpayments, then it's not good enough to have that information analyzed and reported, but it also must feed into the control mechanism and corrective action must be taken. So, to summarize, Medicare says that in order to achieve savings, you have to develop certain core competencies. Chief among these core competencies are patient-centeredness and engagement, care coordination, evidence-based medicine, and point-of-care automation, among others. In order to fulfill these 4 fronts, in order to excel in these fronts, we say that you need to develop an infrastructure which supports real-time access to information, communication and coordination, analysis and reporting, measurement and control. So if you can deploy these abilities within your ACO, then you can achieve competence in the areas identified by Medicare. Let's turn our attention to what this already boils down to. At the end of the day, all these requirements and all these competencies concentrate on one aspect: making the right decision. The Medicare wants the patient to be involved so that the healthcare providers make the right decision at the point of care. Care coordination is necessary so that all relevant healthcare providers are aware of all past circumstances of the patient and so therefore can make the right decision. Evidence-based medicine requires that the most up-to-date research and methodologies be made use of, again, to make the appropriate decision. And point-of-care automation, again, stresses the use of technology to assist a healthcare provider in arriving at the right course of action. So, what's the common denominator? It's the ability to make the right decision. Why? Because making the right decision at the right time improves quality and reduces healthcare costs. Now, in order to make the right decision, we need data. It's not a matter of data not being made available, because the fact is that too much data is made available. It's scattered, it's not readily available, and it's actually overwhelming. Data is currently captured in silos. It's captured in paper records. It's captured on numerous different EHRs based across the healthcare spectrum. It's too much information that's going to be available to any provider to be able to digest and incorporate into their decision-making process at the point of care. So what's needed is the ability for an EHR to incorporate all this information and to assist a provider in making the right decision at the right time and achieving the MSSP goals. So what you need is something beyond our traditional EHRs that exist today. To achieve success on all these fronts, the ACO management needs to choose an EHR system which supports analysis and reporting. Now, what analysis and reporting involves is the ability to capture information from multiple siloed sources, which may very well be disparate EHRs, to consolidate that data into one comprehensive form, and then to process that data into actionable information, which is the analysis part, and then to disseminate that information to all relevant participants, which is the reporting part, so that it positively impacts their decision making. Now, the EHR should provide reporting and analysis capabilities. What does that mean? Well, it basically means that the EHR should not just have the ability to capture data, but it should have the ability to both automatically and manually analyze that data in different respects and report on the results of such analysis. This can be automatic, where the EHR performs predefined analyses, or it should be manual, where the EHR provides the ability to its users to mine through the data as they see fit. What I'm going to do here is provide you with a few examples of the kind of analysis and reporting capabilities that an EHR should be able to provide to ensure ACO success. In each of these, I'll identify the analysis component and the reporting component that an EHR must possess. Again, this is only a limited set of examples, the point being to demonstrate that in order to achieve success, the ACO of choice must be one which supports both analysis and reporting. So, the first example is the MSSP's measurements and reporting requirements. The MSSP has defined 33 quality metrics. Now, the EHR should have the ability to measure these metrics and to determine whether or not an ACO's participants are on track to achieving the minimum thresholds required. So the analysis part turns out to capturing the relevant information, comparing that to the benchmarks, and determining whether or not they're on track to achieving success. The reporting part will involve telling all relevant participants whether or not they're on track. If they are on track, then all is good. But if they're not on track, then the EHR should have the ability to highlight where they're lacking, who's lacking, and what corrective action is suggested to qualify at the end of the reporting period. Next, let's take the example of point-of-care automation. Point-of-care automation involves making use of technology to make the right decision at the point of care and to assimilate all the necessary information in the provider's decision-making process. Now, In order to provide this information, the EHR needs to be able to analyze relevant data and then to report that data to the provider at the point of care. So for example, the EHR should have the ability to automatically create and manually update problem lists. It should have the ability to allow the providers to set reminders as well as show up automatic alerts if the provider is suggesting a treatment or medication, for example, which would in fact undermine the patient's health. Again, in order to provide these alerts, the EHR should have the ability to assess the current circumstances of the patient and incorporate the current choice of action by the provider and assess whether or not the correct decision is being made. Next example, dealing with disbursement of shared savings. Now, the analysis part comes in identifying how many beneficiaries have been dealt with by which providers, and therefore determining which providers have realized the savings and who is entitled to what proportion of savings. The EHR should be able to do this analysis automatically by making use of claims data. The reporting part comes in by providing a simple report and identifying which provider is entitled to what proportion of the ultimate savings. The next example is that of predictive and preventive medicine. The objective of predictive and preventive medicine being making use of the most up-to-date research and methodologies available in order to make the most appropriate decision in light of the circumstances of a particular patient. So when it comes to analysis in this regard, the EHR should have the ability to assess the current circumstances of the patient and to cross-reference this with the existing knowledge that it has in order to provide the most up-to-date and relevant information to the provider at the point of care, which is the reporting part. Now, it's not good enough for the EHR to support automatic analysis and research in this regard, because it may be that no precedent exists in the case of a particular patient, in which case the EHR should provide analysis abilities for the provider to dig in and mine their own data and come up with their own conclusions, the analysis part, and subsequently disseminate that information to all relevant parties, the reporting part. The next example for analysis and reporting in practice is that of measuring and reporting on the performance of the practice and the ACO when it comes to clinical performance, quality standards, administrative performance, financial performance, revenue cycle performance, and provider reimbursement. In all of these areas, the EHR should have the ability to capture the relevant data, analyze it against relevant benchmarks, and report to the relevant personnel. So for example, if we take the example of provider reimbursements, the EHR should have the ability to automatically analyze reimbursements against predefined measures, predefined reimbursement rates, to analyze that, to identify underpayments, for example, and report these underpayments to the relevant provider and the relevant administrator in order to contact the insurance and remedy the situation. So the analysis and reporting ultimately leading towards improved decision making. The next example is of patient engagement and communication. Let's take an example within that, flu shot reminder calls. We all know the purpose of flu shot reminder calls, but an EHR should have the ability to analyze the information to assess whether it's time for a patient's flu shot, whether or not the patient has already had their flu shots this season, and make the relevant decision in sending out a reminder call to the patient, thus informing both the patient and the provider that it's time for the next flu shot. Another example of analysis and reporting requirements in the patient engagement and communication area are perhaps the automatic collection and consolidation by an EHR of data from insurers, from hospital discharge records, and from pharmacies to gain insights into whether or not patients are taking their prescriptions in a timely fashion. And after performing this analysis, reporting on any instances where in fact prescriptions are not being taken in time. Such reports should be made available to the providers automatically, as well as reminders being sent out to the relevant patients to remedy the situation. Another example comes in the form of population health management. Now, an EHR should have the ability to analyze data to identify at-risk populations. It should have the ability to help providers construct new models of identifying at-risk populations and incorporating these models into point-of-care systems so that individual patients at the point of care who fulfill the model's criteria are identified and in a timely fashion communicated to the attending healthcare professional so that corrective action may be taken. So, after having considered all these examples, the point to take away is that in order to be successful, an ACO will have to choose an EHR which has a number of capabilities beyond simply recording data. Among these abilities is, first of all, the ability to consolidate data from disparate sources. This involves both connecting to HIEs and interfacing with other EHRs. The chosen EHR should have the ability to transparently and seamlessly consolidate all this data and make it available in one consolidated form without the providers and the users having to worry about how and when this data is being consolidated. Next, it should provide the users with the ability to manually analyze the data as and when required, but at the same time it should also support automatic analysis of the data and ultimately reporting the results of this automatic and manual analysis to the relevant users. The EHR of choice should span all ACO participants. It should not be limited to the use of providers. It should cover use by providers, nurses, physicians, care managers, administrators, as well as members of the governance board. In other words, it should be capable of catering to the needs of all ACO users in all forms, whether manual or automatic. Summing up today's session, we started off by considering the common characteristics of existing MSSP ACOs. We went on to consider the application process and the timelines associated with that. We also discussed the financial implications of the two ACO models provided for in the MSSP. We then went on to cover a number of practical examples where reporting and analysis is required to achieve ACO success, and the fact that the MSSP, in identifying the core competencies that an ACO must build upon to realize savings and increases in quality, has built into the model reporting and analysis which must be adopted. If an ACO does not adopt an EHR which supports in-house reporting and analysis capabilities, then it cannot possibly hope to achieve the metrics that the MSSP identifies as the determinants of ACO success. And that concludes today's session on accountable care organizations. Should you have any questions or comments of any nature, please feel free to contact us at info@mtbc.com, and Steve or I will get back to you as soon as we can. I'd like to thank you all for attending, and have a great day.